Hello, and welcome to the Duke Endocrinology Conference. I'm Diana McNeill, Professor of Medicine at Duke University Medical Center. We are glad you have joined us. Today's program is titled Inpatient to Outpatient Diabetes Care, Making a Smooth Transition. And our distinguished guest is Jan Nicollerat, Director of the Duke University Adult Diabetes Program in Durham, North Carolina. Jan, thanks so much for joining us.
Thank you for inviting us.
So, Jan, what can you teach us about making the smooth transition from inpatient to outpatient diabetes care?
I think the important thing to keep in mind is when patients come into the hospital, often it's not their diabetes that brings them to the hospital, but it's the complicating factor. And so in the hospital, there are a lot of things about self-care management that need to be conveyed to the patient, but perhaps they're too ill to absorb very much. So it's very important upon discharge that those patients are then connected into their community, either their primary care providers, and to education programs, which can then help them develop these diabetes self-care management skills so they can manage their diabetes very effectively.
And many of these transitions of care are the source of some quality improvement projects right now. So some of our listeners are going to be the recipient of the improvement we hope in communication from the inpatient to the outpatient arena. So where do we start?
Well, I think where we begin is once the patient is discharged, and even before the patient is discharged, the team in the hospital managing the patient will assess their educational needs about their diabetes, and these needs need to be communicated to their primary care provider in the community and or their endocrinology team and or their education team, whatever is established. Some of our patients don't have all those resources established on the front end, but certainly we need to assist them in making sure that they are established at discharge.
So one of the things, Jan, that I think can be confusing to those of us that are taking care of patients with diabetes in the hospitals, who is supposed to make that assessment? Should it be the nursing staff? Should it be a patient resource manager? Should it be an endocrinology consult? Who should make that assessment, in your opinion?
I would say to you that it should be all of those people or any part of those people. A team of providers who cares for patients with diabetes can begin with the nurse. It could even be input from the nursing assistant who's caring for the patient, any physician, primary care, consulting, specialty, as our patients have needs, dietitians, social workers, discharge planners. But the important thing is that all this information is assimilated and then communicated back to whoever is going to assist this patient in managing and designing and help and referring them to the pieces of the community support after discharge.
Many of our hospitals now have actually TV stations that might have diabetes education, or even a brochure that can actually be given as written information to the patient when they go home. I've been struck sometimes, and I know you and I've talked about it, by the decision to start a patient on insulin in the hospital, and then when they leave, no one's taught them how to give insulin, and it's it's right before they walk out the door. So.
And I would say too, and depending on the situation and where, what the resources are in that hospital situation, how much education and what can occur. I would say that learning to give insulin by a television, diabetes education television channel is probably not the optimal way, nor is a piece of paper handout. There needs to be hands-on and face-to-face conversation with the patient as well as demonstration, because we need to know that they actually can do this themselves at home.
That's right.
But things that we would want to take into consideration as well, what are these patients' functional abilities? What can they do in their home? What are their resources in the home? Are there financial barriers? Is there social support?
Right.
Because diabetes is not just about education.
That's right. When you are meeting with these patients before discharge, do you find that the goals that are set in the hospital need to be quickly reevaluated when discharged? Or, one of the things we've been discussing is how soon after you begin this assessment should these patients be seen back by the primary care provider or extenders?
Well, and that's a really interesting question, because there's probably no 100% exact right answer. But I think you have to look at the acuity level of the patient. What brought them to the hospital? How ill they were in the hospital. Many of our patients are discharged very quickly
That's
these days.
True.
And their primary goal is just to get their insulin or their medication on board to build up their nutritional status, which may have really digressed while they were ill. Those people may not have the strength or energy to get out to an education team, and they might not remember it at that point in time. Other people who, if they came in and they were newly diagnosed with diabetes, this was just 100% surprise to them,
right.
They might be just fine to go immediately. So I really think it goes back to individually ascertaining where we are. But I would say, if you wanted a general guideline, that within probably a 2-week period of time, there should be a connection with their primary care provider, whomever that may be, and a link in place to get to an education process.
Okay, very good, very good. Healthy eating. One of the hardest parts of managing diabetes for so many of our patients.
And for America.
For America, that's a good point. That's actually a very good point.
So the exciting thing about teaching people about diabetes nutrition, and people look at us on the education team like we're crazy for saying this, is what we're really asking people to do is eat healthy.
Okay.
And if all of us, with and without diabetes, would follow these guiding principles, we would have much less obesity, better controlled blood pressures, certainly less cardiovascular incidence, and less diabetes.
You know, a lot of our patients who have had diabetes for a few years remember the exchange lists. I know you remember them. We used to teach that in the old days. And I think sometimes patients have a hard time recognizing that there's a little bit more or even a lot more flexibility in their diet, but they have to make good choices. I mean, a lot of it is the choice you make, you know.
Right. And so, and I think that's what we like to emphasize, is that you don't need special foods for a diabetes meal plan.
Right.
And that used to be a trick question
Right.
we would do with medical students. If you remember, we would say, go to a diet manual and show us a diabetes diet, and they would spend a long time looking for this thing that did not exist.
Right.
All foods are allowed on a diabetes meal plan. So if it's your birthday, I'm not going to tell you not to have a piece of cake. I am going to ask you not to eat the whole cake.
That's probably good for all of us.
But it's kind of the portion control process.
You also mentioned on your slide there that there's a lot of healthy foods that you emphasize, but we have some patients who have unique diets. We have people that are vegetarian or vegans, and others who really want to emphasize fiber in their diet. What kind of distinctions do you need to make if you're educating these patients?
You can eat healthy on a vegan diet, and so what we would encourage patients is to have a protein source with all their meals, to have fiber, include fiber, it's very good, and to have lots of fresh vegetables, fruits. And you get more fiber in the peel of the fruit than to drink like the juices of the fruit. So if they don't want to eat meat products, that's perfectly fine. And some people do not choose to include eggs as well, which is all right. Nuts are a good source of both fats and some protein. So there are ways to do that very, very well. And we have many patients who have specific dietary needs, either cultural needs or for other medical conditions. So you can still eat healthy and incorporate those needs.
And I think what you just did is dispel one of the myths, I think, of management of patients with diabetes, because I've had several patients come and say that they were told they couldn't follow their special diet because of their diabetes. I think it's mostly education that we have to give them on the right kinds of foods to eat within their guidelines. You mentioned on this chart a comment that is actually on a lot of our dietary orders in the hospital, which is consistent carbohydrate intake. Can you explain that for our audience, what that means?
Well, and it kind of goes hands in hand with not skipping meals. And one of the unfortunate habits that Americans seem to choose today is to skip breakfast, skip lunch, or eat a very minuscule lunch on the run, and then they're starved at dinner time, and so you see a lot of grazing behavior throughout the evening, with the biggest meal of the day in the evening at the time of the day where we're probably more sedentary. And the interesting thing is most patients don't realize that if you're not eating all day, your body perceives that you are fasting. And you need energy to function. And so where is the energy going to come from if you do not eat. It's going to come from their liver. Their liver is going to overproduce glucose.
Okay.
And in the best case scenario, if they would begin to eat breakfast, lunch, and dinner, they will see an improvement in their glucose levels. And they don't have to eat large meals.
Right.
They don't have to eat 3 meals, but they should have 2 meals and perhaps a smaller snack in between. And that will cut down on quantity at one time a day. So that's what we mean by consistent spacing across the day rather than large amounts one time.
So one thing I think would be important for our listeners to recall is we're all busy in clinic right now. There's a lot of things we have to address with our patients with diabetes because they have many times other complicating comorbid problems. Many times we forget to ask about their diet. I think we decide that we can cover whatever they're eating or not eating with different medications, but it's been my observation, at least, that if we forget to ask about the diet, we miss what you just talked about, which is people skipping meals. A group of patients maybe you could address specifically would be our geriatric patient population with diabetes. A lot of those folks, it seems, tend to eat more at lunch, a little bit less at dinner. Any special considerations there?
In the elderly, I think that we have to be considered, one, that they have access to quality foods, because in skilled nursing facilities or sometimes even in assisted living, sometimes you might see more carbohydrates included in the meal, and the patient actually has less control over their choices. They can make choices from what they're given, but they don't always have the purchasing power or the opportunity to select the meal. So one, what are their choices? Helping them make the best choice possible among their choices, and also making sure that they are getting enough calories, because I will find in some of my elderly patients, they don't have much appetite. And they don't want, it's difficult to cook for one. And there may be depression. There may be fewer or tighter financial resources.
That's a big issue.
And so I do think we have to assess our patients to be sure that they are getting the caloric needs, that they're appropriate.
And then make sure that whatever medical regimen we're using for their diabetes, particularly insulin, matches up. We can get up with severe hypoglycemia. So speaking of that, tell us a little bit about monitoring.
Monitoring blood sugar is really important. And there's a lot of, there's always dialogue among patients about this, because this is their least favorite thing to do. Second only to keeping a dietary food record.
That would be true. That's true. They don't like doing that.
But I call finger pricking, if you will. Patients don't like to do it. I probably wouldn't want to do it, embrace it 100% either. But unfortunately, it is the best data that we have at the present time in diabetes management. So the standards of care in 2010, and also studies have shown that blood glucose monitoring does make a difference. The negotiable part is how frequently patients should monitor. And an interesting caveat here in the standards is patients should monitor if somebody is going to look at their data. So we should not, as practitioners, be asking our patients to monitor if we're not willing to look at the numbers. Patients get frustrated with the numbers when they're not numbers that fall in their target goals, which often leads to cessation of monitoring. And the other problem is money. And the meters are free. The meters can be very minimal.
But by Medicaid and Medicare?
Medicaid provides them with meters and will be covered. And Medicare will cover. Now, the interesting thing about Medicare is whether if you're on insulin or not on insulin. So if you're not on insulin, they might cover 1 to 2 strips per day. If you're on insulin, they'll cover, I think it's 3 to 4 if you're on multiple daily injections or pump therapy. It's up to the provider to write that prescription for the meter and strips correctly, not just documenting glucometer, but specifying the one that you want them to have and how many strips, how many times per day they need to test, and how many strips per month they're going to require. Otherwise, they will not have access to it.
For our listeners, this has become a very important comment. So many of our patients right now are getting their strips turned down by their insurers because of our lack of completeness in documentation. But I think you have a comment on here that actually is something that has some patients querying whether it's something they need to do. You said all patients should monitor daily. There has been some concern that patients who are not on insulin who may have pending diabetes don't need to monitor. What do you think about that?
I have read that, or I've read those studies as well. If you look at changing behaviors, the only way, feedback loop to give a person with diabetes that positive or negative feedback that that behavior is or is not improving their glucose control is some form of data. If you wait for 3 months to go back to your primary care provider, who would be happy to test this for you, you have 3 months that you don't know if your interventions have made a difference or not. So to me, you know, it's easier to give a meter to a patient, but have them monitor less frequently. So maybe they need to monitor 2 or 3 times a week, but at different times of day. Maybe it needs to be not fasting in the morning, but 2 hours after their biggest meal. And if those numbers are okay, then they can go another week. But when people see trends changing, not for the better, but to the higher end of the range or out of range, either high or low, patients should begin to monitor more frequently.
I always tell patients this is a silent disease until you're in trouble, and then it rears its ugly head, unfortunately. Do you have a comment about alternative site meters?
All meters today that I am thinking off the top of my head can be used for alternative site testing
other than fingers.
And the best site, in my professional opinion, is this piece of the fleshy part of the thumb. It doesn't hurt. It has a rich blood supply. There's not hair on the arm, which smears the sample and makes it more difficult for a patient. But the caveat to alternate site testing is if you have a high blood sugar, hyperglycemia or hypoglycemia, low blood sugar, patients still have to do a finger stick to validate that. So in the long run, some providers and some of the literature suggests while alternate site testing is certainly acceptable, patients may perceive there's more sticks involved and say they go back to the finger stick. So I think that's something we have to look at individually with the patients. And the other important message is all patients who use a glucose meter need individual instruction on how to use it. They're not difficult, but user error is 90% of the issue when meter accuracy is questioned. It's usually not the meter. It's usually the user, and it's usually because the user didn't know. So we can make a difference there.
So what goals of blood sugars? You mentioned that originally. What are we telling our patients to strive for?
I think this is really important, is that we tell patients we want your blood sugar to keep in range. We want you to stay in goal, and then sometimes we forget to say what the goal is, which is very difficult to stay in goal if you don't know.
Absolutely.
So this is a good general place to begin and needs to be individualized for each patient. When you wake up in the morning and before eating, goal would be 80 to 120 milligrams per deciliter. 2 hours post-meal, this gets interesting.
It does.
As the Diabetes Association, American Diabetes Association says your glucose 2 hours post-meal or post-prandial should be less than 180 milligrams per deciliter. The American Association of Clinical Endocrinologists would like to see that number less than 140, and most people kind of split the difference and go for below 160.
And are they treating to the hemoglobin A1C here? Where are these numbers coming from, Jano?
The Diabetes Association with this guideline was aiming to an A1C of 7% or less. The clinical endocrinologists, American Association, were aiming to an A1C below 6.5%. So that's kind of where those parameters originated.
And there's some studies ongoing, including the large study that has had some preliminary release called the ACCORD trial, which may give us some evidence behind some of these numbers that will be a little bit more vibrant than in the past. I do think your comment about individualizing for every patient is important. Wonder if a patient does not feel low blood sugars. Do you still use these same targets, Janet?
No, I would not. I would raise these targets instantly. And unfortunately, many of our patients are not blessed with awareness of their symptoms of hypoglycemia until they and the carpet are together.
And so which we don't like.
We don't like. It's not a good thing. And so for those patients, it might be very appropriate to say, I don't want your blood sugar below 150. Okay. Now, there is evidence that if we can get their blood sugar above target for a period of time, in some patients, we may be able to reset that awareness thermostat. These patients, that's not to say that all of their symptoms of hypoglycemia that we as clinicians would hope for will return, but it may be that the patient will note that they feel differently, and that is a signal for them to test.
That's an important pearl for our listeners, I think, because I think once the patient becomes afraid of hypoglycemia, the extender or the physician provider becomes afraid of hypoglycemia, and we all tend to move it up to a level that's a little bit.
And I think, too, if you have someone with new diagnosis of diabetes or has had uncontrolled diabetes for a period of time and they're accustomed to blood sugars 250 and above, and we all of a sudden as practitioners rein them in and say, we want you to be 80 to 120 fasting and pre-meal, they are going to feel really bad. And they're going to feel hypoglycemic at a number of 150 or 180, and they're going to treat that low, which isn't really necessary. So I would recommend bringing them down incrementally.
All right. So tell us, if we do have a hypoglycemic event, what are we supposed to do about it? Jan, I think people give everybody the whole kitchen sink last check.
And I think I am sharing the words of my patients who say this is absolutely the worst feeling on the face of the earth, and that they will eat everything in the refrigerator that is not nailed down to get as far away from this feeling. So that's difficult because that compounds the problem. So what we really want to advocate is using patience and limits, that 15 to 30 grams of rapid-acting carbohydrate in the form of real, not diet, soft drinks,
that's important.
Juices, and that means 4 ounces. That's not an 8-ounce water glass of juice. Or glucose tablets. Usually you have to chew 4 of them. They're usually 4 to 5 grams of carb per tablet. Or glucose gel, which comes out. You just squirt the whole the tube into their mouth under the tongue sublingually, and it's all absorbed very rapidly. All these are preferred as opposed to candy, food, sugar, honey, lifesavers, which you have to chew 10 or 12, raisins, and milk. While milk can be used to prevent nighttime hypoglycemia because it has some protein in it, it has more fat and protein in it. It takes longer to digest, so it will not bring that blood sugar up immediately.
Quickly. Patients really want to eat chocolate. They just really want to eat chocolate. You are emphasizing that chocolate is not a good treatment for emergent management of hypoglycemia.
Absolutely.
Okay.
And I'm a chocolate fanatic, so I'm right there with them, but yes, chocolate is not an appropriate treatment.
What about cake icing? Some of our patients use cake icing.
Cake icing would be the equivalent of glucose gel. It's a quantity, but frankly speaking, if you're having a really bad hypoglycemic episode, hypoglycemia is more dangerous than the hyperglycemia from overtreating. So we can deal with that.
So let me give you a case scenario where people are not sure what to do. So we're getting ready to eat our meal. We checked our blood sugar, and it's 40. We're getting ready to sit down and eat dinner. Do I treat the 40? Do I eat the meal? And if I happen to be on insulin, do I wait and take the insulin? What do you tell a patient to do?
I am so glad that you brought that case scenario. That is a common problem in diabetes. Absolutely. First thing, you treat that low blood sugar. And patients do not want to use their calories and their carbs for treating the low. But if you just treat the way we just discussed, you don't have to use that much. Get the blood sugar out of the hypoglycemic range. Get it up to like 80. Then eat the meal. Now, the insulin question, I would agree with patients. I would be afraid to take my insulin at the start of the meal as well. All of the rapid-acting insulins of today, you may take 30 minutes, within 30 minutes of starting the meal. So if you have a low blood sugar at the time of the meal and you're just not comfortable, I would treat the low, get your blood sugar up, retest to confirm that. Then count your carbs or however you're dosing your insulin, but you can eat first and dose the insulin within a 30-minute window. If it goes beyond 30 minutes, it gets up toward 45 to an hour, you're going to end up needing correction insulin at a later time.
All right, let me give you a second case. This is such a common problem for our patients and our listeners. You have a patient who took their insulin before they ate their dinner, as they perhaps should. They ate their meal. Their blood sugar was acceptable before the meal, and then very quickly after they ate their dinner, they have a rapid drop in blood sugar to a hypoglycemic event. Patients will come in and say, why did that happen? What do you tell them?
It could be that they ate less.
That's right.
Happens in a restaurant all the time. The portions are large, or the food didn't taste as good as it looked. So they took all of their meal dose, but they ate half of it. Depends on where they injected.
Yes.
If they were physically active or had exercise recently, the insulin is going to be absorbed more rapidly.
It's particularly if I always say if it hurt when you gave it, you might have given it into a muscle, which will be more rapidly absorbed. Or if you had profound bleeding after you gave a shot, because normally none of those events occur, then perhaps you hit a blood vessel or something. But I've had a handful of patients where that's been an issue, but that is very rare, is it not, Jan?
It is.
Pretty rare.
It
pretty
is.
rare. So after we've managed the hypoglycemia, how do we take the medications that we want to give them?
Always take the medications as they were prescribed by your physician. That doesn't mean skipping them. That doesn't mean withholding them for fear of hypoglycemia. If you have concerns about that, patient should call their provider and they need to have dialogue. Timing I put to remind us to talk about the very insulin issue that you discussed. Some medications need to be taken with food. Some medications oral do not need to be taken with food. So it's important that we ascertain and communicate that. There's so many oral medications used in diabetes. We're not going to go through them today. But that needs to be an important part of this patient's care plan and discussed with them, and the specific guidelines given to the patient. Many of my patients like to skip their basal insulin or their long-acting insulin or oral medication for fear of hypoglycemia, and that's just not a good practice. And so we need to educate our patients about the causes of hypoglycemia and how the insulin should be used.
And also
to make
how
the
long the
safest.
insulin works. I think some people aren't sure what a long-acting insulin
And the old
does.
insulins, peaked and caused more hypoglycemia. The newer insulins of today that are long-acting do not. And then my favorite.
There we go.
So sliding scales. Often an old term which still is around, doesn't want to die. And then supplemental scale is my preferred use of that word. But sometimes I'll see patients and they'll have basal insulin. They'll have a long-acting insulin twice a day or once a day. And then they're supposed to dose their mealtime insulin based on this sliding or supplemental scale. So if their blood sugar is 225, they would add so many units. This addresses the blood sugar retrospectively. It does not address what they're eating. So that's my objection to that process, is it doesn't cover the food that they're eating. Patients need to know that insulin is part of a diabetes treatment plan. And if you have type 1 diabetes, that is as good as it gets now. But if you have type 2, you can have a variety of options, and you can go back and forth between options. But at no time should any of us as health providers indicate that insulin is a punishment for poor management of diabetes. Insulin is a wonderful treatment alternative therapy, and it is going to be part of all patients with type 2 diabetes at some point in their diabetes career.
That's the natural history of that disease. One of the things, Jen, that's hard sometimes is patients, when they are told they have to go on insulin, do exactly what you just said. They say, has my diabetes gotten worse? Is this the end game? Does this mean that my life expectancy is now decreased because I'm having to go on insulin? So what your comments about how sometimes we go back and forth, particularly if a patient's been hospitalized. And we use insulin all the time in the hospital, even for people on oral medications. And then when they come back to see the primary care providers, often they can go back on their oral medications if they've been stable. But I don't think it's a death sentence. And I think your comments about that are very, very important for us to share with our patients.
And I think when a new patient is diagnosed, that's when the insulin word needs to first be mentioned. And when we do that, then this giant needle picture does not become embossed in our patients' brains, and the fear of the needle, if you will, allow me to say that, ceases to become the issue.
Right. Yeah, you taught me that, when you tell someone you're going to put them on insulin, don't make them stick an orange right away. I mean, let them practice with saline, because I think an orange and a human are not exactly the same thing. So remember that. So what is this supplemental scale that you're talking about?
The supplemental scale would be for, used to be called the sliding scale, still is sometimes. It is a correction scale. Correction insulin. When the blood sugar is not in goal, sometimes we need to take some supplemental insulin to get back down. For patients on injections, I don't recommend that they do this in between meals. I recommend they add this at the time of the meal, and the reason for that is when you're on injections, if you take a rapid-acting insulin at your meal and then 2 hours later you take a correction, those insulins are both peaking, and they will join hands and effectively say, let's render some hypoglycemia here, and that in our business is called stacking of insulin, and as you know, we see this a lot. So patients on injections should be instructed to do their corrections with meals, not in between. Sometimes we give them a formula, which is whatever their blood sugar is minus their target, which has been established between their provider, divided by this number we call the sensitivity factor, which is really, it's a mathematical formula, just kind of an estimate of how much we think 1 unit of insulin should lower the glucose. It's a place to begin. And so we can do it that way. And sometimes we'll just do 5% of the total daily dose for every 50 milligrams per deciliter over 200. And so each patient, that can be individualized. Should not be used instead of mealtime insulin and may be needed, for example, when steroids are used in the hospital or inpatient or outpatient. There are definite appropriate times for this to be used.
I think we don't like the term sliding scale, and I'll even use the term correction, because you're correcting an elevated blood sugars, but steroids, or someone who is not known to have diabetes, who has a stressor in the hospital that might cause your sugars to go up temporarily, sometimes we'll put a correction insulin dose on there, but that is not meant to replace what they might really need if they're not. Yeah. All right. So what else do we have to do to stay healthy?
You need to exercise.
All right. You're not
and we
telling
need to
me
have
to
fun
do
while we
dancer.
exercise. No, you do not have to have be a belly dancer, or you choose that as your exercise mode.
I'll lose patience if I make that a requirement, Jan.
My experience as an educator and a clinician has been getting people to exercise is probably the most challenging thing. And for all of us, I will say it's the most challenging to find time in the day to fit it in. But it's so important, and it's more, I've been more successful when people choose activities that they like. So square dancing, some people like to run, some people like elliptical machines. Whatever you like to do.
Are you a pedometer woman? Do you like?
I like pedometers personally. Some patients don't like pedometers.
The 10,000 step.
The 10,000 steps a day. The guidelines, the 2010 Diabetes Association guidelines for exercise, 150 minutes of exercise per week, with a target heart rate above 80. That being said, there was an article in today's newspaper which stated that if we are female, that we probably need more than that. We probably need double that amount with a higher heart rate and caloric restriction simultaneously to maintain. So it just goes to show it's not an easy thing. But exercise certainly improves one's insulin sensitivity, makes them require less insulin. It produces endorphins, which make people feel good. It's good for your heart. It's a variety of reasons everyone should exercise. So I like this picture because it's for fun. And that's what we need to help people find things that are fun to do. The other point is it doesn't always have to be sustained in one block. So some people, if they say, I can't do it, then fine, do 2 20-minute blocks or 2 15-minute blocks. Just get it in.
Get it in. Excellent. So what else do we have to worry about with our patients with diabetes?
This is my favorite, A1C, hemoglobin A1C, which, as you know, is a blood test. like the anemia blood test, and it measures the number of red blood cells circulating. And as red blood cells are made and circulate in your bone marrow, of course, glucose hops on for the ride. So this is a reflection of the percent of glucose backwards in time over about the past 2 to 3 months. The original goal was 7% or below. I believe actually when I started it might have been higher. And today's goal, we want to aim for 6.5%.
Now, can we diagnose diabetes using this test now?
We now can. The guidelines of 2010 state that we can diagnose diabetes, which would be diagnosed with hemoglobin A1C of 6.5% or greater.
Or greater. And that's really going to be helpful for our listeners, because I think for many of them, sometimes they'll see a random blood sugar and they're not sure if they can actually apply the diagnosis. And the diagnosis is important because it has some impact with regard to procurement of resources from insurers and other things. But I think now that we can do the hemoglobin A1C as a diagnostic criteria, we may actually identify patients earlier in the disease process, which will be wonderful, I think.
That's true.
Blood pressure.
B is for blood pressure. Very important in diabetes management and maintaining a healthy heart. The recommended guidelines, the systolic of 130 millimeters or less and a diastolic of 80 millimeters or less.
Okay.
Should be checked every visit.
Right.
Our patients are going to be on blood pressure medication, even prophylactically. Preventatively, that's a very important part of diabetes care, and patients need to know this goal.
Right.
And they need to know their own blood pressure.
Right.
And then C, of course, is for cholesterol. Important in terms of knowing their lipid numbers. And in diabetes, always we want the LDL cholesterol to be below 100, and we would like it lower than 70 in the face of heart disease.
Right, and I always remind patients, and many of them are not aware of this, I told a couple patients this yesterday, diabetes is a cardiac risk equivalent disease. That means that when I look at you, if you have diabetes, I have to assume that you have had a heart attack. And they go, whoa. I said, no, that's because of the goals that we're trying to approach. There are the goals that we would want you to have if you had cardiovascular disease. So everything we do in diabetes, as you have been so eloquent in explaining, is prophylactic. Next words.
Diagnosis.
Yes.
So this kind of goes back to what we were saying, but the other caveat we needed to probably speak about on the slide is, I'm aging myself, but there used to be a term called borderline diabetes, which you and I were not fond of because no one took this seriously, also called a touch of sugar. And happily was replaced by this term prediabetes some years ago. And now that category is now going to be changing names again to persons at higher risk for developing type 2 diabetes. And the A1C cutoff is going to be 5.7 to 6.4%. A person will fit in this category, which we formerly have called prediabetes. These are people on the road to diabetes, and approximately 40 to 50% will then progress to type 2 diabetes. This is a time where modification of lifestyle behaviors is critical, and where patients can really make a difference here by weight management, modifying dietary habits, and getting physically active, and then looking at those target ABCs. Good. And the A1C correlates to an EAG, another new term in the last year, which is the estimated average glucose. And when we used a hemoglobin A1C of 7%, that number was about 180 milligrams per deciliter. This A1C of 6.5% puts that down to a more tolerable or appropriate range of 140 milligrams per deciliter. And we want to avoid danger words like, if you don't bring your blood sugars down or lose weight, we're going to have you go on insulin or start the needle.
Don't threaten patients. I mean, they already are struggling enough with their diagnosis as it is, and things like cutting off legs and no babies and things like that. Those are things that we don't need to say to our patients. No, we do not. We need to support them.
We need to be supportive.
We need to support them.
In terms of patient goals, my other least favorite word is non-compliance. It's just provider and patient working not in the same direction. And we need to be supportive.
Okay.
That's all I need to say.
Always. So now, when do you call the provider? Now, the provider can be you, it can be the physician, it could be, sometimes it's a pharmacist.
It could be a pharmacist, it could be a physician assistant, whoever is helping them with their diabetes.
Okay.
When they have hypoglycemia without explanation or frequent hypoglycemia, glucose is greater than 200 to 300 over a 2-day period, or more than 200 at the same time of day for 2 days. Always have them return maybe in 2 weeks for a review of their logbook and meter, and setting up appointments with diabetes education team.
And then the other thing I will add is if something causes them not to eat, and I think you mentioned that next. I mean, if you can't keep food down, I always say diabetes requires a match of medication.
Exactly. Fever, chills, vomiting, diarrhea, loss of appetite, any infection, chest pain, shortness of breath, difficulty bleeding, pain in calf or leg, etc. Always merits a call. Always better to call.
I don't think any of us would ever be upset if a patient called and we told them that they were okay. I think that that's not a problem. It's just that if you don't know what's going on, you should check. You should check.
And finally, I think the goal for everyone is to empower our patients to manage their diabetes, because in fact, you and I see them for small windows of time infrequently. So knowledge is power. And diabetes is forever. It's manageable. It's a positive message, not a negative. Life with diabetes should be fun and enjoyable. They should fit diabetes in their life. It changes over time. That's a norm. It's not, and we need to sustain hope, empower, encourage, praise, positive. Always.
Jana, I've worked with you for many years. You embody everything you just said, and in your care of so many patients, and I appreciate the words you shared with us today.
Thank you.
Our guest today has been Jan Nicollerat, one of my colleagues here at Duke. Jan, thanks again for joining us and giving us so many important pearls. Until next time, then, from all of us here at Duke, this is Diana McNeill saying thanks for joining us, and take care.